Doctor, 3, 2, 1, you can start now.
Good evening, everyone. Thank you for joining in on our inaugural episode of a series which is known as the Soliloquy series. Soliloquy actually means the act of speaking one's thought, irrespective of the audience. But this webinar has been designed by keeping into mind our audience. What would they like to hear? What is the topic that they would like to delve in and know more about? But at the end of the day, our star would always be our speaker. This series is a single speaker series so that we ensure that you get proper, good take home messages. And this is something that we had all kind of envisioned, and it could only be made possible under the guidance and support of our president, Dr. Amit Patki, and our secretary, Dr. Asha Bakshi Madam. And we are so happy that our inaugural batsman is Dr. Raj Mathur from UK. So without taking any more time and introducing what our series actually means to us, I would now like to invite Dr. Amit Patki, sir, President of ISAR, to say a few words to our audience and to kickstart this inaugural episode of a series which will happen every second Friday of the month. And I hope you look forward to it as much as we look forward to bringing these episodes for you.
Thank you very much, Ritu, and thank you very much to Dr. Raj Mathur, past president of the British Fertility Society, for being our inaugural speaker. As Ritu aptly said, we wanted something unique in this webinar, and one speaker, one session was the idea that Ritu floated. And we are very glad that Ritu and her team, led by with Sheetal and the rest of them, have devised this, which is going to happen one Friday every month. I'm very grateful to Dr. Raj Mathur, who readily agreed, and I'm looking forward to listening to him and many other stalwarts. The reason for having one speaker is that we give them enough time to discuss, desiccate, and interact with the audience on a topic and have complete knowledge of the same. So without wasting much time, I would like you all to take these proceedings ahead. Thank you very much to Dr. Raj Mathur. I'm speaking to you all from the banks of the river Ganga at Varanasi, and I think I can't have a more better place to sit and listen to Dr. Raj. So to Dr. Raj, thank you.
Dr. Kalyani, can you introduce Dr. Bakshi, please?
Good evening, everyone. Dr. Bakshi is the secretary for ISAR, and we would like Dr. Bakshi to be with us today for the inaugural CME. Dr. Bakshi, we all know, needs no introduction. She is the person who has always been there to guide us and always to take the series forward. So welcoming you, Bakshi ma'am.
Ma'am, you are on mute.
Indeed, it's a great pleasure to be here today and to listen to stalwarts like Dr. Raj Mathur, whom we have already heard many times in the conferences, and he's so updated with his knowledge. And so the Shubharamb is really very good, and I'm sure this series is going to do very well, and we'll have lots of such good programs. And already, under leadership of Dr. Amit Patki, the things have started rolling, and we'll have lots of learning sessions and lots of interactions. So I think instead of talking a lot, let's listen to Dr. Raj Mathur.
I request Dr. Erica to introduce Dr. Mathur, please. आप slide दिखा दीजिए, Ranjit. Yes, thank you.
Welcome, sir. It's my pleasure to introduce you. Dr. Raj Mathur, he's a consultant gynecologist and subspecialist in reproductive medicine and surgery at Manchester University Hospital NHS Foundation Trust. former chair of the British Fertility Society, honorary senior lecturer at University of Manchester, senior consultant at Manchester Fertility, member of the NICE Fertility Guideline Committee, former advisor at the HFEA Scientific and Clinical Advances Advisory Committee, member of the editorial board of the Obstetric Gynecology and Reproductive Medicine. He's a lead author of the RCOG Green Top Guideline on Management of OHSS, lead author BFS Guidelines on Prevention of OHSS, and co-founder and former person responsible at Cambridge IVF. Welcome, sir, and thank you so much for accepting to be a speaker at this series. Over to you, sir.
Thank you very much indeed. I am really humbled and very deeply honored to be asked by the society to start this enterprise, which they call the Soliloquy series. I think this is a fantastic idea. And for you to have asked me is really a very big thing for me, and I'm very, very much honored. If I may be allowed to share my screen, please. Thank you. So my talk today is on the subject of dual trigger, and I'm going to try to look at what the evidence says and how we can move forward with dual trigger in clinical practice. I should start by declaring my conflicts of interest. I have received funding from various pharmaceutical companies in order to attend scientific conferences and deliver lectures. I have full details of this on whopaysthisdoctor.org on the website. I also have a private practice in fertility. So I was interested to see that this is called a soliloquy series. And of course, the most famous soliloquy in the English language is from Hamlet, the famous one which goes to be or not to be. And that's actually quite a deep and I would say dark piece of writing, because Hamlet there is discussing the question of whether it is better to be alive even when your life is not so happy, or it is better to kill yourself. So actually it's an incredibly dark place for a soliloquy. It is only one of 7 soliloquies in Hamlet, but it is the one that's most famous and is the most powerful, I think, of all of those. But to be honest, that is not my favorite soliloquy. My favorite soliloquy is from a much more recent source, and I don't know how many of you know this one. This is the famous Shah Rukh Khan soliloquy from Chak De, India, when he goes into the dressing room of the Indian women's hockey team and he delivers the famous 70-minute speech. You have 70 minutes. He says, these are the most important 70 minutes of your life. And whether you win or lose, you will never lose these 70 minutes. And nobody in the world, in fact, he says, God will not be able to take these 70 minutes away from you. So I prefer the soliloquy to be a little bit more uplifting and a little bit more positive than Hamlet's efforts were in that field. But nonetheless, it is a real honor to be asked to deliver a soliloquy. So the questions that I would like to cover in today's presentation relate to various aspects of dual trigger. And I think in order to understand where we are coming from and how we should use this, we do need to have an idea of gonadotropin physiology at the middle of the menstrual cycle in women. A little bit about what the pharmacological options are for clinicians who want to induce follicular maturation in the course of an IVF cycle. I've then tried to do a strengths, weaknesses, opportunities, and threats, or a SWOT analysis of dual trigger, because I like that model as a way of getting a 360-degree view of a treatment option. And I'll conclude then with some practical clinical considerations. These are my thoughts. They are derived from the literature, but they are my interpretation of the literature. So please don't take them as a guideline produced by a specific scientific or clinical body, but they're my personal opinions, and I'm very, very happy to discuss them And I'm actually very happy to be challenged on them as well, and please do so. So looking at the middle of the menstrual cycle in women, just to remind ourselves of the anatomy and physiology a little bit. So the hypothalamus, particularly the medial basal part of the hypothalamus, has GnRH secreting neurons. And these neurons secrete GnRH in pulses, one pulse every hour. And the GnRH goes into the hypothalamo-hypophyseal portal system. Now, you will all know that a portal system, there are three portal systems in the body. There is the portal vein, but every time you have a vein between two sets of capillaries, that is a portal system. And the hypothalamus and pituitary have their own portal system. Now, the GnRH goes down the portal system into the pituitary gland, into the anterior pituitary. The gonadotroph cells in the anterior pituitary respond to it by releasing FSH and LH in similar pulses. And we know that the FSH and LH act upon the ovary to produce follicular growth and to cause estradiol production. This is all explained by the two-cell, two-gonadotropin model of estradiol production. As estradiol levels rise, and in fact, there's also a very small rise in progesterone at mid-cycle, this leads to a massive increase in the magnitude of LH and FSH. This is usually called the LH surge, but there is also an FSH surge at the same time. Release of the oocyte from the ovary occurs some 36 to 40 hours after the onset of the LH surge, typically in a physiological cycle. And the duration of the increased LH and FSH, or the surge, the duration of the surge lasts approximately 2 days in a normal cycle in women. Within the hypothalamus itself, there are a number of neurons that have different effects on this whole system. When I was a medical student, this molecule did not exist. It's called kisspeptin, but we know now that kisspeptin is very important. Kisspeptin neurons are present in the periventricular nucleus and arcuate nucleus of the hypothalamus. These neurons express not only kisspeptin, but also neurokinin B and dynorphin, so they're called KINDY cells. We know that kisspeptin mediates the feedback effect of estradiol on GnRH secretion. So kisspeptin directly stimulates GnRH secretion. There is a negative feedback effect of estrogen on GnRH, and that is mediated via kisspeptin neurons in the arcuate nucleus. There's a positive effect mediated via neurons in the AV-PV nucleus of the hypothalamus. And this is an example, just a brief diagram, which shows how the same neuron, the KINDY neuron, produces these three products that have this combined effect. Just out of interest, because we see increasingly an interest in people who are transgender, just a reminder that in men, in biological males, testosterone is aromatized to estrogen peripherally. And that estrogen exerts a negative feedback effect on the hypothalamus. But there is no scope for a positive feedback effect in males. There is only a negative feedback effect, as you see in the first diagram of this set. So this is what's happening at the level of the hypothalamus and its effect on the pituitary. And the effect on the pituitary can be seen quite clearly in this diagram, and most of you will be very familiar with this. This is the salient pattern of the important reproductive hormones in a physiological menstrual cycle. There's a few things to note here. Of course, there is an LH surge, which is the blue line. We all know the LH surge. We're all familiar with the LH surge. We know it's preceded by a hump in estradiol production. It is succeeded by a rise in progesterone production, which peaks in the mid-luteal phase. But I want you to also pay attention to the fact that there is, at the same time as the LH surge, a rise in FSH. So there is a little bit of an FH surge. And the LH surge is preceded by kisspeptin, indicating some degree of physiological relevance of kisspeptin in this system. So let's bear that in mind. People have thought about what the FSH surge at mid-cycle might be doing. What is the reason or physiological justification for that to happen? We know from clinical IVF that even if there is no surge in the FSH at mid-cycle, you still get eggs, you still make embryos, and you still get babies. And as a result, most of us clinicians who work in the IVF field think that the physiological LH surge is not important. It's not relevant to our clinical practice. That may be true to a large extent in many patients, but I don't think we should dismiss it simply like that. There are a number of basic science studies, especially in animals, which show that there is a role for the mid-cycle FSH surge. There is a study from more than 30 years ago by a stalwart of reproductive medicine called Insler. And Insler showed that in rat species, the mid-cycle FSH surge selects follicles for the next menstrual cycle. So that's quite a fundamental role in that. But we know also in humans that in vitro, FSH will promote the formation of LH receptors on granulosa cells. So FSH lays the ground for LH to act. It causes cumulus expansion. It is involved in the resumption of oocyte meiosis, leading to nuclear maturation. And that is an essential step before fertilization can occur. We know that hyaluronic acid synthesis needs to occur, and this allows cumulus expansion, and the cumulus oocyte complex then becomes free-floating in the follicular fluid. I'll move on now to just a quick enumeration of what the options are for final follicular maturation that are available to clinicians. We're all familiar with human chorionic gonadotropin, or HCG. This can be used in an agonist cycle, or it can be used in the antagonist cycle. The physiological basis for using HCG is as a surrogate for LH. You all know from your biochemistry that HCG has a very similar structure to LH. In fact, the alpha chain is the same between the two molecules. The beta subunit is 85% similar. But there are also significant differences. HCG has a much, much longer half-life. It binds to the LH receptor much more potently, and it is much more potent in inducing granulosa cell cyclic AMP synthesis than LH would be. So it has homologies and similarities with LH, but it has a much more powerful and long-lasting effect compared to LH. You can get recombinant HCG or urinary HCG. Cochrane review seems to suggest that there's really no difference in clinical outcomes when you compare these two agents. You can also use, instead of an LH surrogate, you can use LH itself. Recombinant LH is actually available for clinical use. It can be used in an agonist cycle or an antagonist cycle. It has if you inject recombinant LH intravenously, the half-life is similar to endogenously produced LH, which is about 1 hour. But if you inject it subcutaneously, half-life is around 21 hours. And this is enough to induce oocyte maturation, enough to induce ovulation. And there was a European multi-center study which showed that it's as effective as HCG in inducing maturation, but you need much higher doses, and also the pregnancy rate is low. The third option for inducing follicular maturation is GnRH agonist. Important to remember, the agonist can only be used as a trigger in antagonist cycles. You can also use kisspeptin, again, only in antagonist cycles. This is not widely clinically available for use at this time because it's not been converted from a research product into a clinical product. And lastly, you can use a combination of HCG and GnRH agonist, which in this case I will refer to as dual trigger. And for people who are interested, this is a very good review article by Baljeev Dhillon and his team in Endocrine Reviews in 2018, and that's a really useful article to have in mind. How does GnRH agonist trigger work? And I think it's important to understand a bit of the physiological basis as to how or why it is even an option. And the key to understanding this is to realize that GnRH antagonist does not cause pituitary downregulation. Very commonly, when we are chatting between ourselves or to patients, we say we will downregulate the pituitary using an antagonist. You can't. The antagonist does not cause downregulation because the pituitary remains sensitive, remains responsive to GnRH. So in a woman who's been on the GnRH antagonist, if you give a bolus of GnRH agonist, that agonist can displace the antagonist from the GnRH receptors and occupy those receptors. It can then activate those receptors, and activation of the GnRH receptors will subsequently lead to an FSH and LH release from the pituitary gonadotropic cells. This will cause an LH and FSH surge. The magnitude of that surge is sufficient for follicles and eggs to mature, okay? And that is the reason behind GnRH agonist trigger. Of course, the half-life of GnRH on its own, native or endogenous GnRH, is very short, 2 to 4 minutes. But by various amino acid replacements, you can produce GnRH analogs with much longer half-lives. And that I've given some examples there that can easily be a few hours in the products that are commonly used in clinical practice. So what dose of GnRH agonist is effective? Because there are a number of agonists have been used and a range of doses has been used. I've described some of the doses and the medications in this slide. I have to say that dose finding studies have not been done on the majority of these. We recently started using nafarelin, and we went straight for the 800 microgram dose, not because we did a dose finding study. We did not have time. It was an emergency situation, but because we thought that's a pretty high dose and would be as effective as any other dose. I'm sure there is potentially a lower dose that would also work. There has been a dose finding study with triptorelin, and that showed that the egg yield was the same whether you use 0.2, 0.3, 0.4 milligram of triptorelin. And I think there is some work that could be done to determine the dose for other agonists as trigger as well. What happens when you give the agonist trigger? We know that there will be a gonadotropin surge. But this is actually significantly different to the physiological surge, and that is the other part of understanding the rationale for a dual trigger. When you do GnRH agonist trigger, there is a rise in LH, which is quite rapid, but it only lasts for 24 hours as compared to 48 hours in the physiological situation. And this 24-hour rise is enough to mature the oocyte, but is probably not enough in most cases to establish an adequate corpus luteum and to support it going forward. We also know that LH, the effect of LH is different from HCG, even though they bind to the same receptor, as we discussed earlier. Even though LH binds to the same receptor on the granulosa cells, it has a greater impact on some pathways, the AKT and ERK1/2 phosphorylation pathway. And this leads to granulosa cell proliferation, differentiation, and survival, whereas HCG causes more activation of the cyclic AMP pathway, which is better at producing progesterone rather than granulosa cell proliferation. At the same time as the LH surge, of course, following a GnRH agonist, there is also a rise in the FSH level, and that might well be clinically relevant. So let us consider all these options together in one diagram and see what the hormone profile is following different ovulation triggers. Along the x-axis, we have time, and along the y-axis, we have the serum level of LH or HCG. You can see instantly that HCG has the most prolonged action, lasting almost a week, and therefore the greatest area under the curve. So the maximum exposure of hormone occurs with the HCG trigger. You can also see that with the GnRH analog trigger, the kind of greeny yellow line, there is a rapid rise in LH levels, but by 24 hours, it has come down to baseline. Okay. If you were to use recombinant LH, you get a slightly more delayed and slightly longer lasting effect. With kisspeptin, interestingly, there is a very similar shape of the curve to a GnRH analog, showing that kisspeptin and GnRH analog work in a very, very similar way. And I just want you to remember that in comparison, the physiological surge will have 3 phases and will last approximately 48 hours. There will be an ascending phase of 14 hours. So that is slower than the GnRH agonist phase. There'll be a plateau of around 14 hours that is longer than with the GnRH analog. And then there is a descending phase of about 20 hours. So none of these actually exactly mimics the physiological LH and FSH surge at mid-cycle. Let us now turn to a SWOT analysis of the treatment at hand. Let us now turn to analyzing from all aspects, from 360 aspects, the dual trigger. What are the strengths of the dual trigger? As I see it, one major strength is that it gives you a physiological LH surge, sorry, physiological FSH surge, which you don't see if you give the patient only HCG. It also increases your endogenous LH levels, which doesn't happen with HCG. And we have seen that endogenous LH can have different effects on the granulosa cells compared to HCG. So that might have some benefits. It might also overcome some of the problems that you get with the trigger alone, because what happens when you use GNR analog alone for trigger without HCG? In some cases, you get a very poor LH response. You get very few mature eggs, and you get a poor luteal phase. This is more likely to happen in patients with a low basal FSH. There are now a number of studies which allow us to identify patients who are at high risk of not responding to the GnRH agonist trigger. And these include patients with hypogonadotropic hypogonadism, with undetectable or very low LH before stimulation, with a long history of combined oral contraceptive use, or previous prolonged use of GnRH analog, for instance, in the treatment of endometriosis. Also, you can measure progesterone levels and LH levels 12 hours after the trigger, and lack of an LH rise, lack of a progesterone rise indicates that that trigger has not worked. So that is now an area that has been studied, and we kind of know what to do if that happens. So these I see as the strengths of the dual trigger. And this the diagram from Schachter publication in 2008 shows that LH and FSH levels are significantly higher in women receiving the dual trigger compared to HCG, and they're closer to physiological situation. What are the weaknesses of the dual trigger? Well, mostly to my mind, the weakness is that we don't quite know where to use it. Do we use it for all patients? Should we use it for some patients? We also don't know what the dose of HCG should be, what the dose of GnRH analog should be. I mean, that is the dose finding studies in combination have just not been done. There's also the question of whether to do a dual trigger, which means giving GnRH agonist and HCG at the same time, or a double trigger where you do both, but you do them at different times. So classically in a double trigger, the GnRH analog is done 40 hours before egg collection, and the HCG trigger 34 hours after, 40 hours prior to egg collection, and the HCG trigger 34 hours prior to egg collection. Also, when you look at the research studies, you find that the studies are on quite variable patient groups, and it's difficult to know whether we can simply combine all the studies and believe in the meta-analysis, or whether we need to look at individual patient groups separately. So in the rest of my talk, that's what I've tried to do. I've tried to look at the studies and see what the problems are, what the positives are, and what we can take home from that research. And I hope we can have a discussion of that. What are the opportunities, though? And this is where we'll come to specific patient groups. And one significant group of patients where I think dual trigger does have a role is in patients where there has previously been a HCG trigger, and you've had a low proportion of mature eggs. So this is, for instance, from Turkey, a randomized controlled trial of women less than 40 who had less than 50% mature eggs in a previous treatment cycle. And they were randomized to either HCGs, which they used recombinant HCG, 6,500 units, 36 hours before egg collection, fairly standard, or a double dual trigger where they had triptorelin 40 hours and recombinant HCG 34 hours before egg collection. And their main outcomes for the number of mature or metaphase 2 oocytes, and also pregnancy outcomes, and they wanted to include frozen cycles because that would take care of cumulative outcomes as well. So what did they find? And this is the table of results. I'll draw your attention to a few. The first thing they found was that there was a greater number of mature oocytes with double trigger, and there was also a greater proportion of mature oocytes with the double trigger. They found that they had more 2PN embryos, more day 3 embryos, and more better quality or high quality day 3 embryos with the double trigger. They did not go as far as blastocysts certainly in their data. When it comes to pregnancy outcomes, they found that the clinical pregnancy rate as a cumulative number was higher with the double trigger. So cumulative clinical pregnancy rate was higher with the double trigger, and cumulative live birth rate was higher with the double trigger. I have to caution that the numbers actually are quite small, and I don't think we can make a strong inference about pregnancy or live birth data, but the numbers are in the direction of supporting a double trigger in this case. What are the specific patient groups? And I spoke previously about women who are poor responders to GnRH analog. And in this trial, Liu et al. Defined poor response to GnRH analog as a low LH response 10 hours after the trigger. And the incidence they found was about 2.7%. In the literature, generally between 1 and 3% incidence is quite common. And they found that if you have a low LH level, you get very few eggs and very few mature eggs. And the retrospective data in this study showed that if you used a dual trigger, you got significantly more mature eggs compared to using agonist trigger only in this group. So then the question arises, well, if it's okay for women with previous poor response to GnRH analog, if it's better for women the first group that we discussed, then why not try it for all? And actually, people have, and people have published randomized trials on this. And instead of going through the RCTs individually, I've looked at the meta-analyses that were done. And in 2021, there was a meta-analysis of 8 randomized trials, and they compared dual trigger with HCG alone. Now, most of these RCTs are on predicted normal responders, but there is one on poor responders by the old Bologna criteria, and most of these don't include PCOS patients. Now, within this, the HCG dose varied from 5,000 to 10,000. The agonist type and the dose was highly variable. The main outcome, the principal outcome of this meta-analysis was live birth rate per started cycle. And let us see what they found. So in their primary outcome, they actually found an improved live birth rate with a risk ratio of 1.37. The confidence interval did not cross unity, so statistically, it is significant. There was not much heterogeneity, and they rated the quality of evidence as moderate. So I would call your attention again to the fact that relatively small numbers of patients, total number of cycles, I'm sorry, not patients, cycles, the total number of cycles was 416 in this cycle. And this was the meta-analysis published in 2021. So when I was updating my presentation, I did another search and I found another meta-analysis after this one, which was published in 2023. This is by a group of investigators from Madrid in Spain. And they did a meta-analysis of dual trigger versus HCG, and they included 6 studies, of which 4 were randomized trials with a low risk of bias, and 2 were observational studies with a high risk of bias. Reading this meta-analysis, I cannot tell why they did not include the 4 RCTs that were included in the previous meta-analysis. Their literature search was completed in August 2021, so that's not the reason. And this just shows you that we've got to look behind the meta-analysis. We've got to see what are the factors that might make its conclusions more or less reliable. So I'm unable to explain why 4 RCTs are missing from this, and if they were genuinely excluded for good reasons, should they have been excluded from the other one as well? The difference in this meta-analysis and the previous one was in their primary outcome. So this meta-analysis focused on the number of oocytes retrieved per cycle, the number of M2 oocytes, the number of 2PN embryos, the fertilization rate, and the number of high-quality embryos on day 3. So these were the primary outcomes in this meta-analysis. And what they found is described here. At the top, you can see that the dual trigger was associated with an increased number of eggs compared to the HCG trigger. There was no significant heterogeneity, and it did not cross unity. But interestingly, there was no difference in the number of mature eggs. There was no difference in the number of 2PN embryos, and there was no difference in the number of high quality day 3 embryos. They did not take it beyond that into blastocysts. In their secondary outcomes, in this meta-analysis, they did have pregnancy rates and live birth rate, and they found, as you would expect from small numbers, they found no difference in those outcomes. So now we are left in a situation where we have two meta-analyses separated in time by 2 years. One deals with 8 studies, but bizarrely, the one that comes afterwards only deals with 4 randomized trials. The two have slightly different primary outcome measures. And while I can't say that there's a contradiction, but there is a certain lack of agreement between the two. Overall, the meta-analyses do not fill me with confidence. And I can't confidently say that the place of dual trigger in an unselected population has been properly clarified. So considering this, we decided that we could look at our local data, and these are data from Manchester Fertility, which is a private fertility clinic in Manchester in the UK. It's a single center study. It's a retrospective study, so please bear that in mind. The value of retrospective studies in identifying causal linkages is very poor, but they can still give us important guidelines or important directions in which to travel in our practice. We had a decent number of patients, over 2,100 patients, of which nearly 1,600 had HCG trigger, and about, nearly 1,300 had HCG trigger, and 950 had a dual trigger. And the headline finding from this was that the dual trigger was associated with an increased number of eggs. On average, we had 1.3 eggs more in the dual trigger group, and also an increase in the number of mature eggs, on average 0.9, or one more mature egg was gained by using the dual trigger compared to a HCG trigger. The HCG trigger used here is Gonazi, which is a urinary HCG. When we looked at the outcomes by female age, we found that in every female age group, the dual trigger was associated with more eggs and with more mature eggs. The only difference was in the age group 38 to 39, where there did not seem to be any difference in the number of M2 eggs. But otherwise, in every age group, there was an improvement in the number of eggs obtained and the number of M2 eggs obtained. We also looked at it by AMH groups, and we found that in most of the AMH groups, from a very low reserve to a normal reserve, the use of a dual trigger increased the number of eggs and also increased the number of M2 eggs. The only exception was the high AMH group, where the AMH is more than 30. And in those groups, dual trigger did not make a difference to either the number of eggs or the number of mature eggs. To a large extent, I think this is understandable, because I think those groups are probably already working at the top of their capacity. And there are some concerns about using dual trigger in that group as well, which I'll come to later on. So let me now go back to my SWOT analysis of dual trigger and just consider briefly the threats of dual trigger. And the main threat that I see is the risk of ovarian hyperstimulation syndrome. We know that if you use GnRH analog alone, it has a lower risk of causing OHSS than if you use a HCG trigger. That has been very clearly shown in a Cochrane meta-analysis, and you will all be familiar with it. We also know that if you use a GnRH analog trigger alone and then give a very small amount of HCG, that increases your OHSS risk. So cases of OHSS can occur, severe OHSS can occur if you use only a very small amount of HCG, only 1,500 units, for instance. The reassuring thing, though, is that the dual trigger does not increase your OHSS risk compared to a HCG trigger on its own. That is reassuring and a good thing to know, and that was shown by the 2021 meta-analysis quite clearly. So that was my kind of a SWOT analysis, a 360-degree look at the dual trigger and the aspects that we should consider. So my personal conclusions from looking at this are as follows. I think the dual trigger, which combines these two agents, at least aims to provide a more physiological alternative to HCG, and also aims to improve some of the problems that would occur by using the agonist trigger alone. I think the clinical evidence is now reasonable for the value of dual trigger, where there has been previously low proportion of mature eggs, and also probably where there is a suboptimal LH response to the GnRH analog trigger alone. And just a reminder that in these groups also, the data are stronger for egg number and mature oocytes, and for pregnancy and live birth, I think the jury is still out and more studies are needed. When it comes to unselected patients or the wider group of patients, I think there are still quite a lot of uncertainties. The two meta-analyses, the quality is not brilliant. I think more studies are needed. I think possibly another meta-analysis is needed of appropriately selected studies. We certainly need to do more work about the dosage and timing of the HCG and the GnRH analog, and whether we should do a dual or a double trigger. Our local data, which are retrospective, suggests that there is not much benefit for using dual trigger in women above 42 or those with a high AMH level. And finally, I have to end this because OHSS is a long-term concern of mine. Please don't use dual trigger in situations where HCG itself is to be avoided. So women with a high ovarian reserve, or where the response is such that you're anxious about the risk of HCG. So with that, I come to the end of my soliloquy. And as you can tell, although this is the voice of one person, but as you can tell from this slide, it actually needs a lot of people to collaborate. We need to do a lot of things together. We need to make a lot of research happen, and we also need to look at the existing research out there and really get from it the messages that we need for our practice. We need to move from soliloquy to a joint effort. So I want to move from that soliloquy that he delivers at the start of the speech to the finale of the film, in which the hockey team is victorious. And I would very much like to thank you all for listening to me today, and I would welcome questions. Thank you.
Thank you so much, sir, for a wonderful talk. I loved the beginning and the end. Definitely the scientific part was amazing. But as we all have heard the lecture, we have definitely come to the conclusion that GnRH agonist is a more physiological trigger, because it does improve the LH and FSH, and it does improve the maturity of the oocytes, and it results in reduction of meiosis. But then, as you said, we need more studies, because there are certain group of people like poor responders and immature oocyte syndrome patients where we can definitely use dual trigger. But in PCOS patients and in patients where we are not sure about the results, how effective it will be. So, sir, I do have few questions. One is that, sir, what do you think, which patient should we use a dual trigger and which patient should we use a double trigger? As in, how do you differentiate between the two?
So I think really there is no proper evidence-based way to answer that. There have been a lot of things that people have tried historically for patients who get no mature eggs, who get eggs but no mature eggs after HCG trigger. And one of the things used to be to prolong the interval from HCG to egg collection. And I think in that situation, I think using a dual trigger in a double format probably makes sense, and it's also backed up by that randomized trial that I showed from Spain. So I think that would be the group of patients where a double dual is reasonable. But in other situations, I think a straightforward dual, both given at the same time, is the way to go. Also, we should remember that we should try not to confuse patients too much. In the UK, patients do all their own injections themselves, and in India, I think most of the time. And the more complicated instructions you give them, the more likely they are to make a mistake, and then you will have no eggs to collect.
Yeah. So the second point I wanted to ask is that when you're giving a dual trigger, especially in poor responders, when do you decide to do the oocyte retrieval? Is it at 36 hours or do you prefer to do it a little earlier?
So we haven't changed our the timing of our egg collection. We aim for 36 hours, but anything between 35 to 37 hours in clinical practice, that will be, and that doesn't seem to alter things that much, but I have to say we haven't changed our practice in that regard.
Okay. So one more question. In PCOS patients, do you think, especially the patients in the previous cycle, they have not got good quality oocytes? In such patients, if you add maybe 1,000 or 1,500 of HCG, do you think, and anyways, we are going to do a freeze-all cycle, so do you think, or are you all using it in your practice?
I think it depends on what you think the reason for not getting a good egg number or mature eggs in women with PCOS is. This has been an age-old problem. You either get very little or you get too much, and to find that happy medium is quite a challenge. I think in the majority of cases of polycystic ovary syndrome where you don't get a good response, it is the preceding stimulation that is important. So I would look at that,
okay,
rather than adding HCG. I'm very anxious about using HCG in women with a high reserve. The research that we did here, my colleague Akanksha Sood published a paper that showed that in women with a high reserve, even if the response is not that high and you give them a HCG trigger, they'd still develop OHSS. It's a lower risk than it would be with high response, but getting a normal response gives you false reassurance. The risk of OHSS still is there if you give them a HCG trigger.
Anybody else wants to ask any questions? I guess. Then I think I'll ask Asmita to conclude. Dr. Asmita? Hi.
Hi. Hello, everyone. This is Dr. Ashmita Pandey from Nepal, the International Coordinator for the Soliloquy series, the first ESAR webinar series under ESAR President Dr. Amit Patki. First of all, I would like to extend my heartfelt gratitude to Dr. Raj Mathur for his enlightening presentation on the topic of the dual trigger. His insights have undoubtedly deepened our understanding and inspired further exploration in this field. I would like to express my sincere appreciation to Dr. Amit Patki, President of ESAR, and Dr. Asa Bakshi, Secretary of ESAR, for their guidance, invaluable contributions, and moral support for the Soliloquy series of webinars. The Soliloquy series is the brainchild of program conveners Dr. Ritu Hinduja, who passionately conceived and executed in a perfect way. And she really deserves an applause, especially for coining the beautiful name Soliloquy, which means a dialogue that reflects an inner thoughts. As we know, teamwork makes the dream works. A special thank goes out to three beautiful national coordinators, Dr. Kalyani, Dr. Sheetal, and Dr. Erika, for the efforts and teamworks behind the scenes to ensure the success of this event. And I would like to extend our gratitude to our academic partners, Mayor Vitabiotics, Mr. Annie and Ms. Akansha, as well as our media and technical support partners, OnFriends. Thank you to all the participants for your active involvement and engagement. Let's carry forward the knowledge gained today to further enhance our practices and make a positive impact in the world of IVF. Thank you once again, and best wishes to all.
Thank you so much, sir. Thank you so much, everyone, for this opportunity. It was a wonderful session. Thank you. Thanks, sir. Bye.
Thank you.
Thanks, ma'am. Bye. Bye.